Welcome to NP's Changing Practice. I am Carol Berger, and we are joined with Nina Zimmerman and Sue
Hi.
Kendig. So tonight we have really been blessed with having Sue with us. Sue, tell us a little bit about you're a women's health practitioner. How many years have you been a practitioner?
Oh my goodness, since 1996, you do the math.
Okay, so you really have been in now, and I mean, you were my teacher, so this is really a special broadcast for me because you were phenomenal and taught us pharmacology. At the time, I remember just being in awe of the fact of how much you knew about your profession and your area of expertise, but you were going to school to be a lawyer at the time because you wanted to change practice. So tell us a little bit about, how you started as a women's health provider and you joined the Missouri Organization for Nurse Practitioners. What made you decide to take that step to go back to school to become a lawyer?
Oh goodness, well, that question is a lot to unpack. I became a women's health nurse practitioner because throughout my nursing career, and I had been a nurse for, oh gosh, probably 15 years before I went back to become a women's health nurse practitioner. And I chose that because I've always worked in some aspect of women's health. Mostly on OB units, every aspect of OB units from labor and delivery, postpartum, special care nursery, all of that. But my background has always been in community health. So I've always had a very community focus, which lends itself well to nurse practitioner practice.
Mm-hmm.
And I became a women's health nurse practitioner because of that passion around women's health. Um, you know, primarily wanting to partner with women to stay healthy throughout their life and to do that within the context of their home and their community. So it was a perfect fit for me. And I appreciate you saying those kind of things about me being as faculty, because honestly, being faculty, I think, is one of the most important jobs we have as nurses and nurse practitioners, because we are helping to prepare the next generation
Absolutely.
of healthcare providers. And when you said, "Oh, I was so in awe of your knowledge," for all the students out there, I have to say, when you are in school, it feels like your faculty just know everything. Here's the secret. We really don't. I used to tell my students, we don't. I used to tell my students that after you are out and you are practicing full time for a year, you will know way more than I do. My job was to give you the foundation. And I can say, I run into my women's health NP students and students like you, Carol, all the time. And that prophecy is right, because everyone that came out of that program that I run into is just phenomenal. So I'm proud of that.
Well, yeah,
Now,
you did a fantastic job, but you also, we do look up and we look at if we could just be like our teachers and we would just get osmosis,
so
all
true.
of their knowledge into our head,
Right.
we would be fine, but you're right. We do just give them that basic understanding and they have to take it from there.
right. And y'all are going to be doing way better than your faculty, because it is your job to take us to the next level. So
Right.
that being said, I went to law school because, given that background in women's health and public health, I would see patients needing care, but not being able to access that care, or not being able to access the services that they needed, because there was some policy, something around reimbursement that was standing in the way, or providers were providing services, but they were having difficulty getting reimbursed. And what that means is sometimes services go away and they close, and then nobody has access. So basically, and I jokingly say this all the time, I decided that healthcare was a mess and I was going to fix it before I died.
I love it. I love it.
And so I had to go to law school to kind of figure out, how do we mesh sort of the intent of policy with the reality of practice and the reality of patients' lives? Because that's really good policy, when you can take the intent And it actually works in practice and makes people's lives better. That's really why I did it. And I can say it was the best decision I ever made.
Yeah, because you were just sitting for boards when I was in your class, and I remember thinking, oh my gosh, she drives 2.5 hours each way every day and still has time to teach me and everything else you do. You know, it was just a really an inspiring story. And the fact that you wanted to really change practice and understand the legalities of changing that, which sometimes just goes, you know, right over our heads. We want to change it, but we don't know how to word it. So tell us a little bit about that legal journey. Where has that taken you? What are you most proud of that you've been able to accomplish?
Oh my goodness. You know, I think it's important to note that I do not practice as a lawyer in the traditional sense. But what this has opened the door to is I've really developed a special interest in reimbursement models for healthcare that drive quality improvement and improve patient outcomes. And I have really developed an affinity for developing new practice models that actually drive that quality improvement perspective. So the law degree has really opened doors because while I am not, you know, going to court, which is what everybody thinks lawyers do, um, you know, I can really understand not only what the law is saying, but also the intent of the law. And when I look at that through the lens of my women's health nurse practitioner experience, I'm really able to inform policymakers, regulators, other stakeholders about how that may actually work in the real world.
Yeah,
And
how is it really going to look?
yeah, and that is a really powerful combination.
Very powerful.
Yeah, so, you know, from that perspective, I've been able to, I think most recently, my work has centered on maternal mortality because the United States, for all of our wonderful healthcare, we have some of the highest rates of maternal mortality among developed countries. And that means women are dying. About 700 women in the United States die each year during pregnancy and the postpartum period.
Wow.
And another 50,000 will have significant medical conditions, significant conditions occur during pregnancy, labor, and delivery that will actually impact them not only for that first year postpartum, placing their lives at risk, but will impact them throughout their life. So it's important for every nurse practitioner, no matter what your population foci is, to understand that if you are working with a woman who is pregnant or a woman who is of reproductive age, one of the first questions we should ask is, have you been pregnant in the last year? Because that's going to drive your differential diagnoses. So in that regard, for 7 years, I sat on the Council on Patient Safety in Women's Health Care. I was the women's health nurse practitioner representative. I was, I think, the only nurse practitioner on the council during that time. And in that process, led the development of national patient safety bundles on maternal mental health and postpartum care transitions to women's health in practice. So really being able to sit at those kinds of tables with other disciplines and help to lead and provide input into efforts that are really affecting practice, not only among nurse practitioners, but interdisciplinary practices are important. You know, one of the things that I am probably the most proud of, although this changes every time I get a new project, there are really two things I'm very proud of. One is there is something called the Women's Preventive Services Initiative. That is a national initiative that is funded by HRSA, the Health Resources Services Administration. And It is led by the American College of OBGYNs, but it has pulled together NPWH, the National Association of Nurse Practitioners in Women's Health, the American College of Physicians, ACOG, and the American Academy of Family Physicians are the 4 core partners in that initiative. And we pull together multidisciplinary steering committees that are with expertise in given preventive services. And the charge is to evaluate and update those existing preventive services that were originated with the IOM report after the Affordable Care Act was implemented to add preventive services for women's health, to identify gaps in preventive services for women that are not addressed by the U.S. Preventive Services Task Force, and to develop new recommendations to fill those gaps. And when those recommendations are vetted, and they go through a very long process, everything is evidence-based, there is public comment. Once those are finalized and HRSA, the federal agency, reviews and approves them, they are then available to women during their preventive services visits without cost sharing, which makes those services much more available. So that's one way that bringing that sort of policy and women's health NP expertise together really is a way. Yeah, it really helps.
Can you
to
give us
drive
an
change.
example of a recommendation that they're toying with, that you know, I mean, like a practical application of how this law works?
Oh, sure. Okay, here's a really good one. This recommendation was just approved during we're in 2021. It was just approved, so I believe it will go into effect in January 2022. It may be in effect now, but you can go to the website and double check me on that, because with COVID, I've lost track of time. But while many of us are familiar with the recommendation on screening women for depression, the U.S. Preventive Services Task Force has a recommendation on screening women for depression, including women who are pregnant and postpartum, so basically across the lifespan. But as you probably know, anxiety affects a significant proportion of women, and there was no anxiety recommendation. So we worked, and last year, the anxiety recommendation, so there is now a recommendation for screening women for anxiety, during their preventive services visits, as well as during pregnancy and postpartum, which was a huge issue.
That is a huge thing.
It is huge. And in practice, we all know when we're screening for depression,
anxiety, sometimes you see more anxiety than I mean, in my own family, I can say anxiety is probably, maybe even the precursor to depression, because they've been dealing with anxiety for so long and not maybe doing it effectively, that it just kind of then goes into a depression or a hopeless kind of situation.
Exactly. And you also know in practice, when we're screening for depression, most of us are screening for anxiety anyhow. But, the other important thing about the Women's Preventive Services Initiative that I think everybody listening to this podcast should know, including our students, these recommendations come because healthcare providers and people in the community who are experiencing gaps in services can go on and make recommendations for the panels to review. So if there is something that you're noticing in care, irregardless of your population foci, you can go onto that website and recommend a topic that we should look into.
Oh, that's really good to know. That is, because, like you said, in practice, you might see a theme, something that you just say, wow, we really should be doing this. And this isn't really the way it is, in my area of interest, it's oral health in children. And what I find is that we have the recommendation, and we have a reimbursement, but it's still not working. It still isn't getting into practice to actually to do it. And part of it, I think, is the reimbursement rate. Part of it is education, but we needed the recommendations, and that's a good starting point, because when I talk to providers that aren't providing an oral health screening at a well child visit, I can say it is recommended. There's recommendation for it. And if there's something new coming up, we could actually make that make our voices heard and say, hey, maybe we should be doing something more.
Right. And, all of us have different opportunities and do different things. So most nurse practitioners are in clinical practice, and they don't have time to do what I do and sit in a bunch of meetings and do a bunch of writing. And sometimes they feel like, well, I really don't have a voice, but you really do, because nurse practitioners give voice to our patient experiences. And this is just one example, by looking at those gaps and sort of elevating that to attention in some of these other bodies and initiatives, you are really carrying that patient's voice forward. And that's really important, because that's how we change practice, and that's how we improve healthcare for everybody.
Right. And then that's what we do. That's what we got into this for.
Exactly.
Absolutely. So you've done some super exciting work for sure, on, just helping bring that nurse practitioner voice with that legal understanding together, to try to help create laws and language that promote reimbursement and policy that goes forward. What would you say to new NPs, brand new nursing students? What legally should they know? What legal pitfalls are there? Because they're just getting into this, and they're just beginning to understand that they're a little more liable than they once were. As an RN, they have a different scope of practice, and now it's kind of branched, and we've got all these different diversities.
Right. I think the one thing that I would say to nurse practitioner students and to new graduates is have a deep understanding of your scope of practice and your competencies within your population foci, because you are now moving into you're able to diagnose, prescribe, and treat. And there's a lot of responsibility that comes with that. So your education our education gives us a foundation of understanding the nuances that are important to our population foci. And while we don't walk out of school as an expert, we walk out with the foundation and the foundational expertise to be a women's health nurse practitioner, an adult gero nurse practitioner,
or family, or acute.
peds, whatever. And when you get out into practice, you're going to hear, oh, well, that doesn't matter. I can teach you how to do that. So, for example, I've had people who are adult gero, and they're working in a practice where they're asked to see children. And when they say that's not in my scope of practice, then they are told, oh, well, that's okay, I can teach you. Here's the issue. Now, certainly learning from our colleagues, from our physician colleagues and our other advanced practice colleagues is important. But when you start to go outside of that population foci and the competencies, and you are relying on someone to teach you that, you may be you're going to learn one person's view, as opposed to that foundational knowledge that tells you when, oh, I got to go look this up. I've got to look at the guidelines.
Doesn't sound right to me,
Right, right. What do I do? And so I think that is one of the most important things, is to really hold and guard your scope of practice and have the confidence that either you know what your scope of practice is, or find mentors to talk to.
So here's another good question for you. So we've all been in this situation. I'm sure maybe you've been in I'm sure we've all kind of had where we have a collaborator, right? And we have seen a patient, And we do have a question. We've got some kind of question that we think we need to ask our collaborator about. We go ask our collaborator, but the answer we get doesn't sit well.
Yeah.
Now there's an issue because legally I'm responsible for my own practice. If I write for that medication, I prescribe that plan of treatment. I'm the one, I mean, I have a collaborator, and I can't say if there's a mistake committed, my collaborator told me to do it. That's
Right.
not a good, that's not going to fly. Right.
Right.
So how do you navigate that? How do you handle that?
Well, the good news is with experience, it becomes easier to handle. When you are first practicing, it's a little bit harder. What I think is probably the most important thing is to know your rationale for why you want to do what you want to do, why you're recommending what you're recommending, or why you're questioning it. So if you have, I always carried my textbooks with me. I did. I always had my protocol
you could
books.
say, hey, I'm not sure about this, right?
Exactly. Or, I mean, we all have internet access now. You can look at the guidelines. So I think the most important thing is have your rationale as to what is making you uncomfortable and what your alternate plan might be, because having a sound rationale that is evidence-based is probably your most important tool in those difficult discussions.
Yeah, because you're going to have to go to that collaborator and you're going to have to kind of say, well, I'm not sure I'm comfortable with that particular decision based on blah, 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 or this is why. I mean, that's what I think I found is sometimes I'm coming to the collaborator because I've done everything I know to do, and I think what we've run into is that collaborator doesn't know what more to do either, and so sometimes we can, just be ping-ponging back and forth. I'm looking for, well, what do you think we should do next? And if they say something that is just off the wall to me, I'm hesitant to want to follow that recommendation. And the bottom line is legally we have to follow our own best. I mean, what is our legal obligation when we're in that collaborative agreement?
Well, you're still, because you remember the collaborative agreement in Missouri delegates the authority to diagnose, prescribe, and treat. So, some of the things that you're going to want to be thinking about is, again, what is that good rationale that you have? What is your evidence? And if you are deviating from that, to document. Discussed with collaborator, here is the recommendation, therefore that's what we've done. Right. But I think it's also important to find your voice in all of this. Let me give you a little bit of an example. Back when I was practicing, and this was a while ago because since I got my law degree, my practice looks very different. But when I was seeing patients and I was in the office, I did not have a physician in the office, and a woman came in and she came in because she said she was in menopause and was having such severe symptoms that she was passing out and had to go to the ER. And she was told that was just menopause and that she should get natural therapies. Well, I don't know anything about natural therapies, so I was not the best person to do that. And I told her that, and she was very, very angry. And so as she was being angry, she said, my triglycerides were 400, and I was told that if I do this, this is going to help. And I'm thinking, okay, that's not good, and this probably isn't going to help. So I sat down with her, and the bottom line was she had some pretty significant lab values and a pretty significant history that had absolutely nothing to do with menopause. And she had seen several specialists, but none of the specialists had talked to each other. So I asked her to go and get lunch. And then I spent my lunch hour calling the specialists and sort of going through this. And in doing that, I was able to piece everything together. And, long story short, but I really felt like she had diabetes. from all that was
Right,
said
from
and done.
everything that you said, right.
So, I talked with the physicians. We came up with a plan. Then I called my collaborator who wasn't in the office, and I said, I just want you to know this, because I was only working like, I don't know, 1 or 2 days a week, and sort of went through this. And he said, oh, well, then we need to send her to a lipidemiologist, another specialist. And I'm like, no, we were number 5 on her list. And
Right.
I cannot go back and say, we're going to send her there. So when these labs come back, either you or I need to sit down with her, and we need to facilitate this. And he said, you're right. Scheduled her to come in. And that's exactly what we did. But it would have been just as easy for me to say, yeah, we probably should do that. But that's the beauty of being a nurse practitioner.
And gaining that confidence to be able to have that voice in that conversation.
And it's also not forgetting that you're a nurse, because what I did was nursing care. And, so even though you may be a novice nurse practitioner, you are an experienced nurse.
That's
and
right.
That's the beauty of being a nurse practitioner.
That, I think you hit a key point where, sometimes a student tends to throw off that nursing cap because now I'm going to be a nurse practitioner. But you're right. It is a part of who we are. And what you did was you coordinated care with all of those physicians and put the pieces together, and then explained it to your collaborator in such a way that he was able to say and see what you were seeing, and advocated for your patient.
Exactly. And as a women's health nurse practitioner, I knew I wasn't going to be the one managing her diabetes.
Right.
But she needed to have that handoff. It needed to be brought together. And so, we really do have a voice, and it's establishing that relationship with your collaborator and not being afraid to, in a very professional way, communicate why you think this is important.
Well, and that's really good. I mean, you brought up a couple of good points. In Missouri, we are under a collaborative agreement that gives us the ability to diagnose, treat, and what we need to do. If that collaborator is not willing to collaborate with us, we no longer have the ability to function in that capacity.
Exactly. And you asked me a while ago in terms of like legal implications and what new grads need to know. And the other thing that I think is really important is to choose your collaborator carefully. Many times when we first get out of school, we want to make a good impression on that interview. And we want the job, because everybody needs that first job, right, to get our experience.
Right.
But you're also interviewing your collaborator. And if you're picking up that it's not going to be a good fit and you can't have these conversations,
then it's not going to be a good fit.
Exactly. And you also need to remember that sometimes what you are wanting to do, even though you have rationale, what the collaborator is suggesting may actually be a different way, and it may be more effective, and they have rationale too. So it's a two-way conversation, and being able to accept those differences and act accordingly in the best interest of the patient.
Right. And like you said, to make sure you document that this was discussed with the collaborator, what plan you decided upon, and how you were going to go ahead and proceed.
Right.
We certainly don't have the right to act independent of our collaborators' recommendations if we sit down with them and discuss it. Correct? Not correct?
That's a tough one, because there may be times when the patient's best interest is at stake. So it's really keeping those lines of communication open. And again, having a good rationale and documenting.
Sounds like a plan. Sue, I can't thank you enough for giving us your expertise, for working in behalf of women's health and the initiatives that you have done. You have done amazing work. You've gone above and beyond being a nurse practitioner, but went on to to learn all the legalities and how you can make your voice heard even more. So I appreciate you, and I know our students will too.
Well, thank you for having me, and good luck to all the students. I can't wait to see you on this program in a few years.
It will be. I mean, that's the whole thing, is we just keep they keep graduating, and then we hear from them and the great things they're doing in practice. And boy, we're stronger together.
Absolutely. Thank you, Carol.
Thank you so much. And that's NP's Changing Practice signing off. We'll see you again next week.